PRAME. Let's kind of just summarize things, make it more understandable for all of you there listening in. First, for those that hear a lot about the chromosome 6p gain is not protective or a good prognostic factor. It's only good if you're comparing it to monosomy 3 or class 2. The 1q gain has been largely overlooked, but it could also be a potential prognostic marker. 8q gain was not specific to metastatic PRAME or PRAME high cases, but is also being looked at. No combination of chromosomal markers were as accurate as PRAME, as Dr. Harbour's group has shown. And in addition of PRAME to GP requires no additional biopsy or extra tumor sample. So when we are testing PRAME, it's bundled with gene expression profile. And so that really just, again, increases the test's accuracy and predictable outcome. And the lack of BAP1 mutation in monosomy 3 suggests that there's a different biological mechanism of metastasis in the class 1 patients. So the class 1 patients are less likely to spread, but there is that second curve that we're starting to pay more attention to and we're starting to decipher. And the finding of the splicing factor mutations in 50% of the metastasizing class 1 patients suggests that these mutations may be associated with the later metastases, again, with the second small hump that we see, and may be of prognostic value. And this is what we're doing now. So you heard about the collaborative ocular oncology group study 1, which validated gene expression profile. And now we're into the second study, and we are really looking into next-gen sequencing. We're looking at these driver mutations, and we hope that this is going to be the seed for us to determine a lot of target treatments for not only adjuvant therapy, but also metastatic disease therapy. And I do encourage you all to go to clinicaltrials.gov and become more familiar with the trials that are registered, but also talk to your ocular oncologist or your clinical oncologist, because they're the ones that will be more in contact with other researchers, other studies, other centers, and they will be able to guide you to the necessary treatment or the necessary trials out there. And where does that leave us? Well, it leaves us with the challenge of personalized systemic management. So through prognostic testing, now we have a way that we subdivide, or we can categorize the folks that need more intense versus less intense surveillance testing. And surveillance testing allows us to identify metastasis earlier and be more proactive about treatment and management of those. And I would like to thank you so much for your attention at this point. I'm going to stop sharing my slides, and I welcome any questions.
Thank you, Dr. Correa. We have a couple of questions here. It was a fantastic presentation. I know you have lots of information you can give folks. And so I'm going to start with the first question from Lisa Hart. It says, can you be both positive and negative?
I'm sorry, I was looking at the chat. I missed your question. I apologize. Too much information.
That's okay. I'll ask you again. It's from Lisa DeHart. It says, can you be both positive and negative?
No. So what we believe is that you are either PRAME positive or negative. And the PRAME, again, is not that it's a determining driver mutation, but it has to do with the way that your body will interact with the tumor, and it will also determine how, again, effective immunotherapy may be, and that's what we're looking into. That's what, our group is currently really dedicated to.
Okay. Thank you very much for that. And this one's a little bit more of a general question, but I feel like it's really important. How do you see the genetics of uveal melanoma impacting the management of patients in the future?
Well, I think it's going to have everything to do with it, because hopefully we will be able to really, through the genetics, determine who is going to go into each different treatment. So all of these new trials, they're all going to show us really what the effectiveness of these different treatments into stopping or preventing the development of metastases. And we hope that at a certain point, we will have all this information, and when the patient comes in, we'll be able to really, after testing them, tell them, here is what we're going to recommend to you, and that will map out their outcome, and hopefully the disease will be much more predictable, just like so many other cancers have evolved by the knowledge of their genetic makeup.
Okay. Thank you. Dr. Correa, I would love to see some more of your graphs again. Is there somewhere that we can go to see them?
Yeah, so a lot of the graphs have been already published between my articles and Dr. Harbor's. There's a lot of that out there, but we're also happy to just share the presentation as a PDF. So we're happy to do that because all of the graphs that we've shown, there's also the reference. And I understand that a lot of times it's hard to just go to PubMed and digest all that medical information. It's a lot of jibber jabber, and we're trying to make it more understandable and easy for you all. So we'll be happy to make it into a PDF and share.
Good. And our team, I think, has your presentation, so we can actually do that on our end for you. We can add that to your profile on Socio, so that way people can find it there in the attachments. Okay, and our next question is, in your class 2, I have METs. I'm going to use METs. I have such a hard time in your class 2 METs graph. It appears that the graph levels off around 7 to 8 years. Does the data continue to support this?
Well, so the data is changing. It's changing very rapidly. And so all of these cancer studies, all of the publications we do, we usually have to wait a long time. We know you can't wrap up a cancer study in 6 months or a year. You know, all of our studies, they have to have mature data because you need at least 5 years to say that something is having an impact on it. So now with PRAME and now with all these adjuvant treatments, we will only see that having an impact on the survival curve of class 2 patients maybe 5 years from now. So I always tell my patients, I say, don't feel discouraged, because obviously survival curves are not up to date to what we're seeing, what we're observing clinically. That still has to catch up. And, you know, even when we submit anything for publications at cancer journals, we a lot of times get feedback from the editors saying, well, but there's not enough survival data. So we have to have an average survival of all the patient group to a certain extent, and we have to have an overall even longer survival. So let's say we just found PRAME a couple of years ago. We still don't have 5 years of follow-up to see how this is going to unfold with the new trials and everything else. I hope that answers the question.
Okay. I've got our next question. Do you think there will be other options in the future to assess patients' genetics?
Yes, so this is again one of the things that we've been brainstorming. Obviously, I'm sure that all the folks out there know that there are not all the centers. I'd like to rephrase that. Not all the centers would offer biopsies for every patient, and there are certain limitations and technical difficulties to certain tumors to be sampled. So our challenge in the future is to come up with a liquid biopsy, with something that we can correlate between what we see in the eye and what is out in the bloodstream. So that's one of the challenges that, our group is looking into right now, and hopefully it will bridge that difference that we have currently.
Okay. And do you think there will be, I have a question here, so people can vote their questions up, and so they're kind of changing it out. Small tumor, class 1A, coupled with Monsomy 3 and 8Q gain, would you classify as high risk?
No, I wouldn't, but I would have to know how this result was obtained. Was it, were both biopsies obtained at the same time prior to treatment? Were both biopsy sites similar? Because what happens is, especially in the melanomas that come from a nevus, and some of them may have this transformation. Depending on where you sample, you may missample. And that's another challenge, again, of the biopsy. So if you're sampling, if you got both samples from the same area, then I would say maybe you just don't have monosomy 3 in all the cells. You know, maybe you're a moderate risk, but it's hard to say. Now, if you got the class 1A result by biopsying an area of the tumor that doesn't look very aggressive versus the monosomy 3 from, you know, the thicker portion, then I would say, gee, that's a hard one to assess because, you know, you have slightly conflicting. It's not usual. You know, not usual that you would get such conflicting results, but it's really a matter of what were the circumstances in which they were obtained.
Okay, thank you. That's great information. I have to answer your question there. And now we have one from Lynn Hauser. How would you recommend PRAME vaccine for class 1A negative? If so, where can you get it?
Probably not, you know, so the PRAME vaccine is not being used still for our uveal melanoma patients. This is something that the group from Immunocore is looking into, a drug that is going to specifically target PRAME. We like to tell people that there is a PRAME vaccine, but you know, we're not still using it regularly, and I think that that's an important piece of information. It's just to say that number one, it's an area that has been looked at, and number two, there are potential targets to it, and finally, number three is that it's already being developed. It's already in the works for other cancers, and us, you know, as an orphan cancer, I'm sure you all realize that we have to really collaborate with the other bigger cancers and be able to use some of the things that were developed. For instance, you know, the EP-Nivo protocols were really borrowed from cutaneous melanoma. So we need to be able to understand enough about the tumor, about the genetics of the tumor, to be able to correlate things that are being done in other areas and hopefully use the good stuff, borrow the good stuff that makes sense, and then try it for our orphan cancer, which is uveal melanoma.
Okay. And then this was also is a question about the vaccine. When is anti-PRAME vaccine indicated?
Well, so like I said, currently we're not using anti-PRAME vaccine, but you would speculate that it would be something viable or possible in patients that were PRAME positive, that then you would do the PRAME vaccine to activate your immune system to go against, you know, the cells that do express PRAME or avoid PRAME from interfering with your T cells.
Okay. And then this is from Lisa DeHart. She's asking another question. Does PRAME positive react better to immunotherapy?
So we believe that they will react better to immunotherapy. We believe that, you know, all evidence points to that way. But again, we still don't have that data ready. So this is one of the things that, again, the new drug from Immunocore is looking at. So what I say is when you have a class 2 tumor or PRAME positive tumor, you have to understand enough to ask good questions, to go to your doctor and say, okay, is there a trial out there looking at PRAME? Is there a trial out there looking at high risk BAP1 mutant cancers? You know, so that's the objective here. We don't have still outcomes data on metastatic disease or good adjuvant treatments, but there are multiple studies out there. And again, there's no one size fits all. We know of stories of patients that do extremely well with some of these drugs, and we know others that just don't respond. And that's where this group can drive the research, can push the envelope, turn the needle to the side of great outcomes and very quick progress in terms of research.
Absolutely. And I know we talked to Dr. Kevin Kim yesterday, and he was talking about trials also and how it's really important to take your time and really educate yourself about all that there is to know about your diagnosis. And so I thought that was a really important discussion. We have one more question here. What factors would you put a class 2 PRAME negative into the medium surveillance rather than high surveillance?
So the other thing that we would consider for a class 2 PRAME negative patient is age of the patient. We would also consider how big the tumor is, and we would put it in the medium surveillance because we again believe that even if you're class 2, but if your immune system is okay, if your tumor is not expressing PRAME, which is the kind of the bully of your immune system, we do have, or you do have, a better fighting chance against metastasis. And I hope that makes sense to you. But things that we also look at is how old is the patient, how large is the tumor, other things like that.
Okay. And we have a question from Peggy. Is the standard of surveillance changing for 1A PRAME negative? In parentheses, yearly checks?
Yes, so PRAME negative class 1A patients, we get the scans once a year, and I tell people it's mostly for our own peace of mind because it's very, very, very unlikely that they will have any other metastatic disease or any other events. So once the primary tumor is treated, we really just want to keep tabs on it. I think it's important for the group to understand that unfortunately cancer, there's multiple things that happen. It's not just about knowing the primary cancer, but it's knowing how the cancer will interact with the host patient. So the same cancer in one person or another one may have completely different outcomes, and that's why we're looking at the genetics, and that's what is driving our research, because we want to understand all of those little variables and all those little things that each person will express or have, and how can we target them more focused. We don't want to be giving chemotherapy that is extremely toxic and terrible for patients to everybody. We want to be able to, again, identify who is who, which group do you fall into, and how can we give the best possible custom treatment or personalized treatment that will be minimally toxic with the best benefits.
Perfect. Okay. And then I have from John, what if any information is available on OM being hereditary? Should my children be monitored?
So that's another great question, because although there have been very few families identified and published or reported in the medical literature to have uveal melanoma, we know that uveal melanoma has everything to do with your ethnic group. It has everything to do with your ancestry, and PRAME is another reason why this is kind of, it's turning our focus to that. But again, we still don't understand if this is something that would be kind of passed. There are some cancer predisposition syndromes that we know of. There are certain folks that have mutations that make them very susceptible to multiple different cancers, but we still don't have a OM or a uveal melanoma predisposition syndrome or a marker, because again, BAP1 is not a mutation that you would see everywhere. There is, like I said, there are some patients that have the BAP1 germline family mutation, but those are kind of rare exceptions. I think that if you're worried about it, you should talk to your oncologist about that. Because this is about 1% to 2% of melanoma patients only that will have the BAP1 germline family mutation, and have yourself tested.
Perfect.
Before you get all the family worried about it.
Well, it's great that there's a test
Just
out
get
there,
tested.
and so yeah, absolutely. Take the precautionary measures if you feel so inclined. Then not knowing will kill you faster than anything else.
Yeah, well, and those are mostly the patients that will have the class 2 tumors that will be, you know, at risk of being in that subgroup. So the test for the BAP1 germline mutation is available. I don't have any financial interest, by a lab company that's called Invitae. So all oncologists out there, clinical oncologists, ocular oncologists are aware of that. So again, ask the good questions, ask the right questions. I think somebody's asking about what ethnic group do you see it in most, the uveal melanoma. It's the Caucasians, you know, it's the Caucasian ancestry. But we can see it in folks of, you know, Hispanic sort of presentation that have some Caucasian in the background. We can see it in folks that look and identify as African American that can also have some Caucasian in them. So it's again, if you're blonde, blue-eyed, it's easy to find you. It's easy to see who you are. But there's a lot of people. I mean, my father's blonde, blue-eyed. I don't look like that, but I know 50% of me is entirely Caucasian. So I know that I am at risk as well. So I think that that's important to understand, because I've had a lot of patients come up to me with African-American sort of, you know, looks and everything, and say, but how did I get this? This is just impossible. And no, it's not impossible, because, you know, in a global world, who knows, you know, what is in the background, what we're made of.
Okay, well, thank you for answering that question. We've got a few more here, and we've got about 7 minutes, so we should be able to cover them all. What about choroidal melanoma? Is it a whole different ballgame?
Choroidal melanoma, you know, I'm using the term uveal melanoma, and that applies to iris, ciliary body, and choroidal melanoma. We know the choroidal melanomas are more prevalent. They're more common than the iris and ciliary body. We know that the iris are the ones that are least aggressive, and so we think, and so that's what we say. However, some people think that iris melanomas are less aggressive simply because we detect them when they're much smaller, because they're visible. They're right there in front of you. But, you know, but I'm using the term uveal melanoma to really encompass the whole, you know, iris, ciliary body, and choroid.
Perfect. I've got 2 here. What factors would put a class 2 PRAME negative into the medium surveillance rather than higher? Did we answer this question already? I think we
already.
Okay. All right. So this is we have another one that popped up here, but we have, can you biopsy liver mets and do genetic testing?
Yes, you can. You definitely can. So, you know, for liver metastases, I think most oncologists or surgical oncologists are tending to get next-gen sequencing. And in the next-gen sequencing, you do get all the different driver mutations, the BAP1, the splicing factor, and all the other ones. So it also helps to be able to look at the core driver mutations of uveal melanoma, because that distinguishes, for instance, when you're looking at a liver with metastatic melanoma, it's hard. For instance, some people have had cutaneous and uveal melanoma, and to think, okay, is this coming from the eye or is this coming from the skin? So biopsying the liver mets and testing the liver mets also gives us this information, because obviously, again, the treatments would be different and the response to treatment is very different.
Okay. And this one's from John Simmelman. Yeah, my screen's a little bit blurry here. It seems that there are more and more cases of OM being discovered. Is this disease still considered rare?
It's still rare. And, you know, we think that it's not that it's more and more cases being discovered. We think that probably the prevalence is about the same, but we're detecting it earlier and earlier. And we have internet and we have communication. So we're much more aware of it. We're much more plugged in and networking and exchanging information. So all of that makes a difference. And again, if you before would only be treating and looking at medium and large tumors, you were missing a hunk of small tumors. And as we're learning more about the genetics and all that, it's making, again, turning the needle. You guys are doing that too. We're turning the needle towards treating it earlier in hopes to avoid the tumors that, evolution and acquiring more mutations and becoming more aggressive. So.
Well, good. And I think that's good news to be able to discover it earlier. And, and I don't know all of the process of the diagnosis, but what would be considered catching it early? I mean, what's the timeline for that? Is there any sort of evidence on what's considered early, detecting it early?
Well, early diagnosis is when you detect the tumor when it's still of a small size and hopefully a class 1A tumor, PRAME negative. That would be early diagnosis. A small melanoma is a melanoma that is less than about 8 millimeters in diameter and up to 3.5 millimeters in thickness. And the diameter is the largest diameter. Because when you hear your doctor talking, the doctor may say, oh, this is, 8 by 6 and 2 millimeters. So it's 8 millimeters in largest diameter, 6 millimeters in smaller diameter, because they're usually not this, cute little round thing. They can be oval. They can sometimes look almost like a map. So they can have any sort of unusual or usual shapes. So there's the largest, the smallest diameter, and there's the thickness. So anything that is still on the small size and class 1A PRAME negative is considered early diagnosis.
Okay, thank you. And we've got one other question. I feel like some of this might have been answered earlier, but what about choroidal melanoma and PRAME?
I think we already addressed it. We think that PRAME, which is an antigen that is really manifested always in the testicles, so it's something that is passed along generation after generation. We think that it has something to do with your immune system and your ability to fight diseases and cancer. And we think that has been sort of the small variant that initially the class 1 and the class 2 tumors that we were seeing that, there was a cluster, but it didn't perform perfectly. And we think that that's the host variable, and that's the PRAME. So there are other questions here. Are melanomas grow to mutations pile on, or are the tumors born with the mutations they have? That's a very good question, and something that we ask ourselves, because sometimes the melanomas, this is from Sue Stewart, because sometimes, we catch small tumors and, we biopsy and we already see a very aggressive genomic profile. And we say, oh my gosh, this is very unusual. So we believe that there's probably 2 different sort of pathways for these tumors. One is that they would transform from what we call a nevus, from a benign lesion or a benign spot that is composed of these melanin carrying cells. And the other would be that, the tumor would already start out as a bad, mean thing. We don't know which ones and likely to the other. We have seen patients with a melanoma in the eye and a small freckle or a small nevus in the same eye. So it's hard to say exactly the initial triggering mutation and how that is going to impact that pathway the tumor will have.
Okay, so I know that you're going to be in your lounge, in your table.
Yes.
We're
going to be at the Bascom Palmer. Yes.
Correct.
Table.
So if you have more questions for Dr. Correa, please feel free to meet her in there and to network with her. We're going to take a short break, and then when we come back, we're going to have the standard of care in OM. And don't forget to look at your event game in socio, and we'll be back in just a few minutes. Thank you so much.
Thank you all for watching. It's been a pleasure. Thanks for the invitation.
Absolutely.